Good morning. I would like to thank the PSA and Dr. Grace Catalan for organizing this session, which continues to highlight the importance of simulation in our specialty. Today, I'm not going to try to convince you that simulation in healthcare education has definitely made a positive impact on patient safety. Instead, I'd like to speak with you about the impact of simulation technology and technique on the learning process of our trainees, and hopefully change the mindset of some educators who may think that simulation based learning is expensive and in order for it to succeed, advanced technology or equipment is vital. This will be my focus points. In the late 19th century, William Halsted deployed the See One, Do One, Teach One method to train students in the Johns Hopkins University's surgical residency program. But in this day and age, the 21st century, this teaching method has been challenged. What we now know as education by random opportunity in live patients is unethical because of the concerns for patient safety. So, how can we improve our teaching and assessment of our trainees? As educators shaping the next generation of anesthesiologists, we can use simulation, an artificial representation of the real world process, to achieve education goals through experiential learning. Healthcare simulation is actually a range of activities that share a common end goal to improve the effectiveness, efficiency, and most especially the safety of our healthcare services for our patients. Healthcare simulation encompasses various domains, some of which are education, simulation based assessment, research, and finally, health system integration. However, let us first go through some operational definitions in simulation. The so called simulation lingo. This healthcare simulation dictionary actually is owned by the Society for Simulation in Healthcare, which is used by several agencies involved in healthcare research and quality assurance all over the world. Let's define technology. Technology refers to a group of materials and devices created or adopted in a simulated environment. For example, computer based virtual reality simulators, high fidelity static mannequins, plastic models, animal products, human cadavers. It actually refers to an educational tool with which the learner physically interacts to mimic an aspect of clinical care for the purpose of teaching or assessment. Simulation technique. Simulation technique is actually a broad description of the simulation experience, consisting of one or more of the following: computer or digital based simulation, simulated patients, simulated clinical immersion, procedural simulation. Just to reiterate, technology refers to a device or material, while a technique refers to the whole simulation process. Now, an integral aspect of simulation is fidelity. Fidelity is the realism associated with a particular simulation activity. It is the believability or the degree to which a simulated experience approaches reality. So, in this case, can you tell which bag is real? Fidelity can actually involve a variety of dimensions as follows. The first is conceptual fidelity. In healthcare simulation, conceptual fidelity ensures that all elements of the scenario relate to each other in a realistic way so that the case makes sense as a whole to the learners. For example, vital signs are consistent with the diagnosis. That is an example of conceptual fidelity. The next is physical fidelity. This refers to the degree to which the simulation looks, sounds, and feels like the actual task. Functional fidelity, on the other hand, refers to the degree in which the equipment used in the simulation responds to the participants' actions. For example, a simulation requiring a ventilation alarm A static ventilator would offer a low functional fidelity compared to a working ventilator. Environmental fidelity, on the other hand, is the degree to which the simulated environment, for example, the mannequin, the room, the tools, the equipment, the moulage, the sensory props, replicate reality and appearance of the real environment. This is environmental fidelity. Psychological fidelity is defined as the degree to which the trainee perceives the simulation to be a believable surrogate for the trained tasks. So, the extent to which the simulated environment evokes the underlying psychological processes necessary in the real world setting is psychological fidelity. Now, this is very important for the assessment of both technical and non technical skills. For example, imagine an operating room environment where the surgeon is placing pressure to get the operation started, and upon induction, the patient suddenly desaturates and all eyes are on you, who will make attempts to secure the airway. What emotions will you feel? Remember, physical fidelity is not as important as psychological fidelity for simulation learning to work. Now we go to high fidelity simulation versus high fidelity simulators. They are often mistaken as one and the same, but essentially they are not. High fidelity simulation refers to simulation experiences that are extremely realistic and provide a high level of interactivity and realism for the learner. It can apply to any technique of simulation, for example, human, mannequin, task trainer, or virtual reality, and does not need a high fidelity simulator. A high fidelity simulator, on the other hand, refers to the broad range of full body mannequins that have the ability to mimic at a very high level human body functions, also known as a high complexity simulator. Low fidelity, on the other hand, are simulation exercises not needing to be controlled or programmed externally for the learner to participate. So examples would be basic written case studies, pen and paper, objective structural clinical examinations or the OSCE, role-playing, task trainers used to support students or professionals in learning a clinical situation or practice. High fidelity simulation provides the most realistic experience, primarily using computer-based mannequins, and may also use cadavers or animal tissue. These techniques are needed for situations that cannot be replicated safely using living patients or lower fidelity mannequins. They are used to teach advanced skills such as surgery and advanced anesthesia. When considering the level of fidelity, more or higher fidelity is not always better. Assuming that students learn in proportion to the level of realism is the fidelity trap, and simulation educators must avoid this trap. Making a funny analogy, it doesn't mean that a grandiose and lavish weddings may forever lang. So low to medium fidelity simulators are actually more cost-effective as they help the learners, especially the beginners, focus on individual tasks and smaller key concepts. High-fidelity simulations are usually reserved for advanced techniques and refinement of processes. At the present time, there are about 80 or more commercially available simulators for use in anesthesia, with their prices ranging from $100 for software-based simulators to more than $50,000 for high-fidelity patient simulators. Now, some studies show that with high-fidelity simulators, there is a tendency to think that there is more learning. However, this increasing complexity of high-fidelity simulators may actually contribute to higher levels of extraneous cognitive load. So what happens? Effective learning is actually sacrificed just for the sake of increased realism. This is what you call cognitive burden, which refers to the information and stimuli which are present but not necessary for the prescribed learning. If the burden is too heavy, this leads to cognitive overload and ineffective learning. So, what can we do? Actually, decreasing this extraneous cognitive load by simplifying the learning environment can actually improve learning. Here are actually some studies which have suggested that high fidelity simulation is not actually more superior to low fidelity simulation in terms of learning or acquiring skills. So, what are the conclusions of some of these studies? First is that high fidelity simulation based education is a highly acclaimed but expensive and resource intensive method. It's not cost effective, especially in developing countries. Most studies support the contention that there is no advantage in learning in a higher degree of realism of the simulator. Participation in the high fidelity simulation may lead to misconceived self assessment in terms of actual abilities and consequently overinflated self confidence. Most trainees prefer shorter, low fidelity simulations that help them master individual tasks, as high fidelity simulations usually place more mental strain on the user and allow for fewer mistakes. Remember, not all simulations need expensive state of the art devices. No patient simulator, no matter how technologically advanced, can ever mimic the human body perfectly. A well run simulation on a low fidelity mannequin is preferable to a poorly run scenario on high fidelity simulation technology. Having said that, we must emphasize more the learning objectives and the processes and not the outcome of the simulation. This promotes learning in a culture of safety. So, how else can simulation from low to high fidelity result in effective learning? This is where your fiction contract comes in. The fiction contract is actually an understanding between the trainee and the facilitator that each will do his or her best to believe that the simulation is real, making the whole process worthwhile. It is also known as the suspension of disbelief, the concept that encourages the participants to put aside their disbelief and accept the simulated exercise as being real for the duration of the scenario. This is what a fiction contract would look like. The fiction contract can be said in this manner during the pre-brief. We will do all we can to make the simulation as real as possible. Simulation fosters active engagement in a safe learning environment. Your role is to enter into the spirit of simulation, engaging with the patient, family, and other members of your healthcare team, as if the situation were real. This will provide you with the best active learning opportunity. Remember confidentiality. What happens in the simulation stays in the simulation. You should come to a simulation with a non-judgmental attitude and be open to learning from your patients, your peers, and your faculty. This is the fiction contract. Now, other techniques that will make your simulation process a success are debriefing and feedback. Debriefing and feedback have been identified as the most important components of healthcare simulation to ensure effective learning. Debriefing occurs either post-event or during within event, the simulation. Identifying debriefing as a facilitated reflective conversation is an important distinction between debriefing and feedback. So debriefing is bidirectional, while feedback is viewed as a one-way conveyance of information to the learner. It is usually unidirectional. There are varied methods of debriefing. I won't really be discussing them in detail. Please note that most methods of debriefing are applied theories of experiential learning. The most common method of simulation debriefing is facilitator guided post event debriefing. It occurs after a simulation scenario and is effective for achieving learning goals and understanding correct and incorrect actions. Within event debriefing involves interrupting the simulation scenario for short and focused debriefing events to allow for coaching in real time. Now we go to rapid cycle deliberate practice, which was introduced by Hunt in 2014. It is a type of within event debriefing that rapidly cycles between deliberate practice and directed feedback until a skill mastery is achieved. Now, I'd like to share with you this is a research actually on how a department of anesthesiology in one of the universities in Malaysia prepare their staff upon being designated as one of the COVID referral centers in their country. This was done by formulating a 2-week intensive simulation and evaluation program applying different educational philosophies applied to healthcare simulation. Notice they were able to effectively prepare for the challenges they anticipated during the initial COVID pandemic, and they focused on technique and strategic planning more than technology. And they applied several theories of learning, some of which I will just breeze through. They identified 3 areas of priority as their needs assessment identified. Number 1 is keeping the staff safe. Number 2 is appropriate patient movement that would decrease the risk of COVID exposure. And finally, the expected clinical scenarios such as patient evaluation and airway management. So this diagram summarizes the workflow for planning, implementation, and evaluation of this 2-week intensive simulation program. The department actually applied 3 educational strategies for their simulation program, namely the Harden's 3-cycle model for outcome-based education, the rapid cycle deliberate practice, and finally, Peyton's 4 steps for skills training: the demonstration, deconstruction, comprehension, and performance. I will go through this very, very briefly. The 3-circle model is a model for outcome-based education and is described as 3 concentric circles. The core skill to be performed is represented in the innermost circle, or doing the right thing, as in airway intubation or safety training, donning PPE. The middle circle represents the correct approach, doing the thing right, as in content and instruction based on institutional needs. And the outermost circle represents the professional performing the skill, or the right person doing it. So the practicing clinicians as instructors, while the learners performing the procedures. Another strategy they used was the rapid cycle deliberate practice. It was chosen as it is efficient for specific skills training. The 3 underlying principles of repeating right away, which provided learners with multiple opportunities to do the right thing, and then you have expert feedback and psychological safety, where the focus is on coaching and practicing in a safe environment, which is clearly an advantage. Here, there is deliberate practice, meaning you are practicing with a clear awareness of the specific components of a skill that you are aiming to improve and exactly how to improve them. So you look at the loop, it's like a cycle loop, it's an iterative loop where you try to improve until you become a master. The 3rd strategy they used was Peyton's 4 steps for skills training. This is demonstration, deconstruction, comprehension, and performance. So they use this for skills for difficult airway management. Several clinical scenarios were used, probing to elicit inadequacies, followed by formal debriefing to facilitate reflection and then improvement. So, what did they actually conclude? They said that simulation based training was a useful preparation tool for small institutions with limited time, limited resources, and manpower in developing nations. Simulation is such a versatile educational tool, and the way we use it is even more important than the tool itself. Unknowingly, we have been doing some crude form of simulations ever since. Role playing, scenario based learning, case scenarios. We just probably have to improve on these learning techniques and enhance the learning of our trainees. More than technology for a simulation program to be successful, we need commitment and dedication of trainers willing to teach the next generation of anesthesiologists without putting our patients in harm's way. And hopefully, they will train the next generation in similar ways. In this day and age of upholding patients' rights and advocating patient empowerment, it is no longer acceptable for trainees to practice more invasive skills on real patients. So, even before we think of investing on 3 million peso simulators, probably let us invest on programs which will nurture us to become good facilitators, effective debriefers, and better teachers. Thank you.